Well, thank you everyone for waiting for a couple moments while we adjusted for technical issues. But want to welcome everyone to our August town hall meeting. And we're going to kind of go through highlights first before we do our program. So we're kind of flipping the agenda real quick. So I want to go over a couple of different highlights of some programs and things that you need to be aware of. And we'll be putting some of the information in the chat as we go along this evening. First, let me switch over. First thing I want to bring everyone's attention to, and we'll be sending this out again through Constant Contact, everyone. IPHA is and NASPA have partnered together to do a national workforce survey. We're trying to gather information for everyone. I know some states have done workforce surveys and we've talked about it from time to time, but we really want to try to, as we step forward earlier this year with both IPHA and NASPA issuing the fundamental rights and responsibilities of pharmacists, specifically with workplace issues. And we want to make sure that we're trying to address everyone's concerns, but we need data and response. So when we send this out, please send it to all your peers, regardless of their members. And it could be a good opportunity for you to engage, to talk to about what IPHA is doing on a state and national level to help address some of these workforce issues. Second thing that I'll be putting into the chat is just a reminder that registration is now open for conference. We are still planning to be in person for October 21st through the 24th at Hilton at the Ballpark St. Louis. And so registration is open. So please make sure you go ahead and book your rooms and register. And there's a full schedule there. With it being a joint conference again, so it'll be a slightly tweaked schedule. We're also trying to do a little bit of a different formatting, trying to be aware more of your free time during conference as well. And as we sent out earlier in the week, actually maybe in the end of last week, we talked about vaccination from the misinformation virus. IPHA and NASPA are financial partners in helping support this documentary that has been created to help address and combat a lot of the misinformation that's out there. And yes, it does spotlight on COVID, but it's about all vaccines. And so this is being broadcast in partnership with PBS. And it actually is now available on PBS's website. But we are actually going to be doing some screenings ourselves that we'll be offering hopefully later on this month. We were working on one of just doing one as NASPA of the state associations doing it, but we may be partnering with a national organization in addition to other states for this statewide or nationwide broadcast from the pharmacy associations. I did want to play the trailer for you, so I want to play that for you now.
Our lifespan for most of human history was short, right? We had 40 years if we were lucky.
Let me guess, you didn't hear the sound on that, right? You could, yeah. Let me
I heard it.
Sharing real quick. I forgot to tell sharing I was going to be doing sound. So
our lifespan for most of human history was short, right? We had 40 years if we were lucky. And 45% of kids, depending on the era of history, died before the age of 5. And when you think about our lives, we get to see our children and our grandchildren grow up. The expectation is if you have a baby, you're going to get to see that baby grow up. That wasn't always the case. So the idea that we get these long lives, we get to see our children grow up, we can expect to see our children grow up. This is a gift of science.
You know, I think we've forgotten a lot of lessons that we've learned over the last 100 years since vaccines were developed. There was a big polio outbreak, devastating. Then we developed the vaccine and we called it cured. We were free of polio. Likewise with measles, mumps, rubella, scarlet fever.
The medicine that has saved more lives than anything else is vaccines. Not insulin, not antibiotics, not medicines for blood pressure. It's vaccines that have saved the most lives. It's really a remarkable contribution to human health.
It's now possible, for misinformation to appear on your computer screen and for you to quickly share that with 1,000 of your closest friends. That's the basis for misinformation to quickly go viral. We're facing a threat from misinformation itself as a viral epidemic of sorts.
So viruses, many viruses are incredibly contagious. They can suspend in the air. People can cough, sneeze, or touch another surface which someone else touches, which is then accentuated if those same people board an airplane or a train, cross continents, cross countries, and then before long, you have a virtual explosion of the virus all around the globe.
This is truly an unprecedented situation.
This virus does not discriminate. It attacks
The
everyone.
coronavirus has changed life as we know it across America.
I want to talk about the fact that if anybody's doubting getting the vaccine, please get the vaccine. This is not a hoax. This is real. It's very dangerous. It comes on quick.
And like I said, we'll be having screenings of that at least once this next month, and we may have a couple others as well. We were going to do a public screening at the office, but with current conditions, I've closed the office again to the public. We'll be looking at different ways of trying to help expand and offer access to this. We're not able to share the video directly onto social media as of yet. That'll probably be closer till December. PBS has the rights for the online, so we may be showing it, pushing information to their website in the interim when we're not doing our showings. But we want to make sure we're sharing this with everyone as much as we can to help try to persuade people. It does seem like I'm hearing that there has been a uptick in some vaccinations over the last couple of weeks. I think people are finally realizing, yes, everything is still on fire, and it's getting a little hot. And so I'm hoping we can help persuade some people with proper information. As you saw in the trailer, John Grabenstein is part of this video project. He is one of the pharmacists who was basically at the beginning of when we started pharmacist immunizations in the mid-90s. So it's good to have him as part of this information as well. Lastly, and then I will turn it over to Starlin and Sabi, I do want to talk about one of the great things that happened last month, and that was the signing of House Bill 135. Which advances us with being able to provide patient care assessment and consultation for women who are looking for treatment for contraception. And there's really one of the things that we really need to be focusing on here, and it actually ties in very well with what Starlin and Sabi are going to be addressing this evening, is this will be shifting us into the era of provider payment for the patient care services that we offer. Now, granted, it's going to be limited just to contraception, but it's a beginning. Now, Starlin's going to be talking about some of the opportunities that already exist in Medicare and some of those other opportunities, but this is going to be what we're going to be able to help establish on a state level through Medicaid and on a state level through commercial insurance. So this is a huge change for us. And, you know, we've talked about provider status on a federal level. This gets us all three green lights that we've been needing on a state level. And we've been working on this for over 20 years, because it started about 1999, 2000 with definition changes to the Practice Act. And so we're finally here. But I did want to share with those of you who were not able to see the governor's bill signing. We did have a bill signing with Governor Pritzker, and I do want to share with his remarks from the bill signing. And we were very fortunate that UIC College of Pharmacy was our host, and we were glad to be able to have this bill signed at one of our schools. So let me shift over to the video.
Well, thank you very much, Glenn. I want to express my gratitude to the UIC College of Pharmacy. You heard Glenn say something very important for people to remember, that the majority of pharmacists in the state of Illinois were trained right here. That's an important marker. We're at one of the great institutions in our state, and I'm really appreciative of the opportunity to make this announcement today right here. This is one of the longest running and best colleges of pharmacy in the entire nation. And we're proud, truly, in the state of Illinois to have an institution of this high caliber. It's fitting that we're here because this legislation that I'm signing into law today makes Illinois one of the first states in the Midwest to provide birth control over the counter, making contraceptives all the more accessible and affordable in our state. I want to recognize the bill's sponsors who are standing behind me, Senator Melinda Bush and Representative Michelle Mussman. I want to thank them for leading the charge. Thanks to you, more Illinoisans will have more control over the most personal decisions of their lives. I also want to welcome the other champions for women's health in the room, the leaders in the General Assembly behind me who have done such a terrific job, not only helping to pass this legislation, but expanding the rights of women to have control over their own bodies and decisions about reproductive rights. And I want to thank Dr. Michelle Brown, an obstetrician gynecologist at Northwestern Medicine, Mary Clafetta, the director of the Women and Reproductive Rights Project for the ACLU of Illinois, and Garth Reynolds of the Illinois Pharmacists Association. Right now in Illinois and in most states, a woman looking to access birth control has to navigate a maze of requirements, hunting down a doctor or a clinic, finding an appointment time that works for them and or for their time working at school or working at their place of work or going to school, accessing transportation to get where they need to go, finding a babysitter to watch the kids while she's away, all to eventually still have to go pick up their pills at the pharmacy staffed with skilled medical professionals. Not to mention, hundreds of thousands of Illinoisans live in contraceptive deserts where there isn't even reasonable access to a health center in the first place. I don't have to have been through all those challenges myself to know that there's got to be a better way. And as of January 1st, there will be. Trained pharmacists using the same screening forms that a physician would use will be able to provide 12-month prescriptions for hormonal contraceptives, whether pills, rings, or patches, to a patient directly over the counter. Whether to prevent pregnancy, manage conditions such as PCOS, address severe period symptoms, or even reduce risks of ovarian cancer, more accessible. In 2019, when I signed the Reproductive Health Act into law, I said that in Illinois, we guarantee a fundamental right is a woman's right to choose. Today, we take yet another step to fulfill on that promise. So thank you, and now I'd like to turn it over to the bill's terrific
Now, of course, the only part of that I wish they would have ran by us was the phrase over the counter. That's caused me more ulcers in the last 2 weeks than anything else. But there hopefully, there should be a good article coming out from the Peoria Journal-Star here pretty soon that I think will help address some of those issues. But I don't want to get too far ahead since I haven't seen all of the article. But I did want to share that with you. I mean, it's a massive day for us. This is legislation that we've been working on with this particular bill for almost 4.5 years. And we will be issuing a training program coming soon. We're talking with a couple of the nationwide experts in this area that we're actually fortunate are members of ours, and we'll be taking a look to see what type of programs will be appropriate for Illinois. But without further ado, I know I did take up a little bit more time than I wanted, but I do want to turn it over to our program this evening. I want to turn it over to Starlin and Asabi to go through billing basics. And I will, Starlin's already got control, so she just has to share her screen. Over to you, Starlin. Just need you to unmute.
Okay, so now I can't find my, there it is. Never mind. I found it. Okay, so this is a lot of slides that will, I'm not going to read them all to you, but I thought you wouldn't need them for your reading entertainment because it contains a lot of definitions and it contains a lot of codes to help you kind of map out as we go along. It is impossible to do a billing program in 20 minutes. So Sabi is going to be watching the chat box for any Q&As that if you need some expansion, if when we get going. She and I have nothing to disclose. And the learning objectives are to discuss the history and billing terminology important to the development of community-based pharmacist-directed clinical services, identify those stakeholders that support that community-based pharmacy-directed clinical services, and describe the available billing and reimbursement models to support our community-based pharmacy services. For technicians, it's the same, except they're supporting the pharmacists in this. And if you don't have a billing technician, you need to get one. So the first pre-assessment question is, which of the following are true? So you'll have to listen for that. You may already know the answer to that one. And the second pre-assessment is CPT codes are. So these are the two big areas in pharmacy right now. So first of all, I want to warn everybody to not put any specific prices or rates or anything in the chat, or if we call on you and unmute you, not to talk about any of those rates. You can say Medicare rates, but we can't talk because we're a healthcare organization of pharmacists, and it could be considered price fixing, and this would be a violation of antitrust laws, which is also the reason why we use Medicare as reference points, because we can talk about their prices. And important to note, if you bill a Medicare plan in any program in your pharmacy, or if you are part of the Medicare Part D MTM services and get reimbursed like Outcomes MTM, and you cannot provide services free of charge or at a reduced rate for any other patients, that is considered Medicare fraud. So if you're going to do something for your church for free, like a brown bag review, please do not put on the sign medication management review or anything like that. So you have to be very, very careful if you're part of that. The other point is we don't have an easy button. When we start developing these profiles so that we can start billing at a patient level, it's just as complicated as what the physicians and the hospitals and the groups have to do. And our goal is, after 15 years, we're much better now than we were when we first started in the diabetes program in 2005. There's been a great deal of expertise pulled in, and we have e-care plans and more networks. So that's the environment's better. We have a unified national state pharmacy association and networks that are working together for that. And it seems that we have more and more pilots and demonstration projects with CMS, with the enhanced MTM projects like Minnesota had, and then the state of Illinois and the city of Chicago have a CDC grant. The state is the 1815 and the city of Chicago has 1817. So we have some small gains in reimbursement to pharmacists at the state level. Garth just talked about House Bill 135. I'm so pumped about this. And the other great thing that we experienced in this COVID pandemic is that we ran toward the fire. And we have filled gaps in healthcare across the nation, and pharmacists have really stepped up to do their part. And I know many of you are burned out because it just when we thought it was over, it's back up again. But we want to fire up for pharmacy for you guys, and we want to thank you for all your dedication. In case you didn't know who was part of the Joint Commission of Pharmacy Practitioners, these are the primary organizations, and your executive director, Garth, is president of NASPA, so he gets to attend the Joint Commission of Pharmacy Practitioners, and so he has a big voice in that. I served on it in the past, and now he is part of it as a NASPA person, so he will have more up-to-date things. I think he was just in a couple of his meetings recently. So let's talk about what pharmacists are known for, what our niche is. So our niche is optimizing medications. And this slide is a complex slide that describes the breadth of pharmacist services and that meet patients' needs. So as we start with intensity to complexity, going from left to right, you will see the patient care services that are around medications. That's our primary process. And we can divide up in buckets this is not all inclusive, but this is a majority of the functionality of patient care services that pharmacists in a community-based pharmacy or anywhere can do. So immunizations and med adherence and preventative services, med reconciliation, dosing services, Part D, MTM, patient safety, discharge. If you see, it's starting to get more complex as we go, right? So these are all drug-related problems, but these are at the very end are much more complex and take much more time and require more documentation and processing. And so you can say that probably most of the dispensing services are toward this end. This is very important. It's still about optimizing medication, but again, as the intensity and complexity goes, we get deeper until we get to the comprehensive medication management. And the other thing that we need to realize is when we're on this end of what we do so well, our patients and our providers and our stakeholders may not really know that we can do all this. So we have to remember to update and brag on ourselves a little bit and educate. And you can believe it, when we start getting the birth control training going, we're going to be probably trying to do lots of radio shots and newspapers so we can spread the word on that. So who's your local stakeholder team? So everything, I believe, and in our 20 years of doing the IPHA PSMP process, we know that healthcare is local. And so if I'm up here in Springfield, I really don't know what's going on down in Harrisburg, Illinois. So we have to have a C-suite level physician liaison. We need a community-based physician champion partner, their primary care office manager, and nurses and office staff, including the nurse practitioners and the physician assistants. And here's our pharmacy team as part of the stakeholders, but there's other pharmacies. We have a pharmacy leader. Do we have a pharmacy leader? Yes, we have Garth. We have all of you on this call tonight. All of you are pharmacy leaders as well as pharmacists. We need great pharmacy technicians. We need the help of our student pharmacists. And I'm pushing this billing technician because when we start getting intricate, we're going to have somebody just focused on making sure that those bills are entered. And lo and behold, our home delivery drivers can be our eyes and ears when we can't be with our patients either telephonically or telehealth. Then at the top of the stakeholder list are the admin, and you could say the government or the people that help make the rules. So if you're working with a health system or even a large physician group, there's going to be a clinic operations manager. Everybody in the physician billing world has a compliance officer and a billing department lead. And then, of course, we're all technology now, so there is a health information analyst. And that health information analyst is the person that will be able to get you the metrics and the details that you need. And we all in Medicare answer to the regional Medicare administrative contractors, and I'll talk more about that later. So when we're talking with physicians and we're trying to create a relationship with them, we always in healthcare could talk about the triple aim, which is safer patient care, better population health, and lower costs. Well, the physician groups, not just the AMA, they call it the quadruple aim. And this is really important. So yes, they want better care, they want lower total medical costs, and they want more satisfied patients, but they want one more thing. The one more thing they want is satisfied providers. And if I wish we had time to put the clip of Dr. Brown, the OBGYN, who gave her speech at the House Bill 135 signing, because she is thrilled to death that pharmacists are going to help her meet the need of her female patients with oral contraceptives. And she hugged us all. She hugged Laura. All of us that were there, she was just hugging us all. I want to tape her, and I love her to be a keynote. But the fact that we're gonna take some of the burnout away from her and then share in this collaborative process is just going to be super. And we're going to be able to show our state and everybody else what more we can do. So again, it's important to pay attention to your state rules and regulations. My tip on this is if you are on a border state, you not only have to know the state that you live in, but the state's rules and regulations of the place that your patients live in. We do not have a compact pharmacy license agreement yet. So either you, when they're at the facility, let's say they're from St. Louis and they come over to Edwardsville, which is across the river, or they're in Indiana and they come up to Chicago. While they're in that site, you practice under Illinois. But when they move, when they're home and they're at their home state, then you have to abide by their state's state regulations and rules. And as you know, not everybody has the same standing order and collaborative practice agreement process, and not every board of pharmacy does exactly the same thing, unfortunately. Okay, you know that our health system is shifting from a fee-for-service to a value-based models. This increases the engagement of pharmacists in models like medical home and ACOs, accountable care organizations. We have embedded models, we have contracted models, you name it, we have a model for it, and they're trying to get the metrics so we can see which one is the better. There's not going to be one better model. Like I said, healthcare is local, so Minnesota's model will work good in Minnesota. Illinois is going to have our own sets of models. And I think we have 50 states and 50 independent thinking processes. And I think that's how it's going to be in some of these models. But in general, CMS and Medicare is supporting those. Why we do Medicare is generally what happens is the commercial insurance covers it. So this is from Troy. Troy gave me this slide to share with you to show how our fee for service is a pre-encounter that we have none. We have one big encounter. So you get the tip if you're doing outcomes MTM, and then you go over and do the comprehensive medication review, and then you document it, and then you may not see them again. You might want to follow up, but by the time you want to follow up, the patient's disengaged. What our new models are based on are a population management model, which is exactly the model that we use for our diabetes self-management program on IPHA PSMP. But now we're going to expand and not just work with self-insured employers. This is an intensive initial assessment start with a pre-encounter, and then so generally there's a little more time spent here, and then the next encounter then builds onto the post-encounter, and then hopefully you're able to keep contact before they get disengaged. And those type of payments are usually per member per month or per member per year. And in our case, we did a per member per quarter for the PSMP. And for those of you that are familiar with the ICPIN, these are the same value that are required to be part of that network. And how we're rebooting IPHA's concepts is that we're going to be involved in all of it. So there'll be the PSMP will also be part of IPIN, which will also be part of any of our other practice models. So I have a slide later on this. So again, we're talking about Medicare. Medicaid, as you know, is a horse of a different color. Even though CMS creates this set of rules for Medicare and Medicaid, Medicare is a federal program. Medicaid is a split program between the state and the feds, and the state gets to decide how much matching they do with the feds. So if they get 75% matching, they have to abide by 75% of all the CMS rules. If they only do 25% matching, then they only have to abide by 25% of the Medicaid rules, if that makes any sense to you. So when we started the DUR program after over 90, we were at a 90 match, a 90% match. So 90% of that entire program was exactly how that Social Security law was written. And then over time, it went down to 50%, but I think it's back up to 75% right now. Although in the state of Illinois, they've moved most of their Medicaid over to managed Medicaid. And so there's another set of rules for that. Then the private payers, and then the value-based model. So the private payers usually follow suit if Medicare, that's why we're trying to get provider status with Medicare. If Medicare gives us provider status, then everybody else will follow suit. But we might with our birth control bill, we might be negotiating with Medicaid on making us providers for the dispensation. Also, if you're wanting a full detail of, I'm only covering the first 2 or 3 pages of this billing primer. It's available at APHA at this link right here at the bottom. It's excellent. It goes into way more detail than I have time to do. So back in 2016, my Compensation and Practices Sustainability Committee came up with this billing opportunity for ambulatory care services by pharmacists. And now in 2021, we're not in these silos anymore. So it just used to be kind of strict with physician-based and hospital-based and community-based, but now transitions of care, chronic care management, and annual wellness visits all can be billed with community pharmacy as long as you have contractual agreements with that. We'll go over that. So when you start thinking about billing, you need to think about where the service is provided. So some of you, especially if you're a faculty and you're embedded somewhere, you could actually be embedded in all of these kinds of service provided. And each one of these has a specific billing process, which is why I can't do billing in 20 minutes. But so it's important to pay attention to where it's taking place. And so you could do all of them, or if you say, I just want to focus on one thing, then that's probably the place you should start. But it's all about where your service is provided and who pays the bill. So quickly, we're just going to go through some really quick medical terminology that you need to know on the medical side. This will help us for you'll understand this terminology when we start building our rules for our billing of our birth control. So the Health Common Procedure Coding System, known as HCPC, that describes what was done. Those are your CPT codes. Then the International Classification of Disease is the ICD-10, and that's why it was done or for what diagnosis it is. And you know that was just revised recently, and I think they're working on an 11, and then National Provider Identifier or a tax ID number for a large group. But usually in a group, you submit both because they want to know specifically who the provider is and what organization and so that's who did it. And I don't know if you know this, but pharmacists have an MPI, but RNs and LPNs do not. So they want it, that's what they want. They want an MPI number, but they're not recognized as providers either. And then the relative value unit, RVUs, this is how much the service is worth in Medicare. And they do RVUs in commercial payment, and this is how the doctors are measured. The interesting, if you see down here where all this information is coming from, this CMS and the American Medical Association have a collaborative agreement of AMA creates the CPT codes, CMS enacts them, and then they work together to create the relative value units. And it's based on regional numbers as well. So somebody in California, Los Angeles, California, is paid differently than someone in Spokane, Washington versus Springfield. It's all regional and geographical. So the current procedure terminology, that's what CPT codes are. That's accepted for documenting medicine. You know, we have some MTM services, our own CPT codes. You also know that during COVID, they created COVID specific for vaccine. Each vaccine has its own code, and the other processes that came along on COVID testing, they created a whole COVID set, and they update that quite often. And as you know, if you have a CPT code, you need to have an ICD-10, and there are others. There's G codes. Well, I've got a few series slides here that talk about where you can see some of the codes, and you can read these later. I'm not going to read it off, but I've tried to show you where you're doing, this is with a physician contract, and this is what we can do when we're just recognized as the provider. And DSMT is on here, but what's not on this needs to be updated is we also can be part of an accredited DPP program and get reimbursed directly. So here's the review of the MTM. You know that it was in law, you know that it's comprehensive, and now it can be, doesn't have to be face-to-face. It can be, you can use telehealth technologies. So these are the codes. What I want you to understand is that MTM Part D is only a small sliver of the medication management that is out there for self-pay insurers, self-insured employers, those value-based payers. Comprehensive medication management is a big thing because the number one reason why people go to the hospital is for adverse drug reactions or inappropriate drugs or not enough drugs, or everything's very drug oriented. As you know, I'm talking to the choir. Here's another chart that shows you, oh, I move my, sorry. This chart shows you the remote physiologic monitoring, RPM, which is like the CGM, the continuous glucose monitor. We can get paid for that, but you have to be contracted with the patient's primary physician to work that. So you can go in and create a little niche there. Then Medicare Diabetes Prevention Program, that's what we're in the middle of providing in our 1815 grant. And these are some general, these are 2020s prices, reimbursements, to give you an idea what is being given on that. And the medication therapy management, you already know. I couldn't find a price on that because it varies by the secondary provider. And then DSMT is the Medicare diabetes self-management training, and this is basically what it is. And so most of these are training is done in a group process, so you can get like 12 to 15 people, and then it makes it a little more lucrative instead of one-on-one like we do with PSMP. It's important for you to know the level of evaluation and management codes that auxiliary personnel, that's what we're called, can provide. And I put this in here so that you're aware that the Medicare Administrative Contractor is the controller of that designation. So as you can see, Illinois is in with Wisconsin and Minnesota, and that's a good thing because Minnesota is like ahead on all the pharmacist billing, and they were MTN Innovator Center, and so hopefully they're demonstrating for that MAC what Wisconsin and Illinois can do. But it's kind of like a pack group, right? But I will also tell you that the MACs talk to each other, and so what we're concerned with in the pharmacy, national pharmacy world, is that each of these regions don't give the same permissions. So what people can do in North Carolina isn't what people can do in California, so forth. And people say that's because of our scope of practice, but that's not necessarily true. When we had a chance to talk with them, we discovered that most of the contractors hired nurses to be the auditors, and the auditors don't think pharmacists can do patient-centered care. So they just think of us as just dispensing only. And so now we're sending all the contracted MACs across the country some of the same information that you're reading here. We send them our billing primer, and we're trying to create a dialogue so that they don't block us out. Okay, these are some more definitions, and it's about supervision. It's important for you to know that CMS clarification timeline on whether pharmacists could bill in the EMM codes higher than 99211 has been over a debate since 2014, and the Family Practice Organization loves pharmacists, and they got permission, and then we had another response, and then we wanted an explicit statement, and so in May of 2020, so that's when we were in there talking to them about all the things that we needed for COVID. We were finally deemed auxiliary personnel, and now every year CMS and AMA revamp the physician fee schedules, which is the clarifications on what the E&M codes, and in an effort to reduce paperwork, they changed that area of E&M codes. So now the only area we can bill at is 99211, which I'll show you. So before, you got to be careful what you ask for. Before, we could bill in all these areas, and these obviously paid more money, and now we can only bill there. But we're working on that. That's part of this work study group, and we've also surveyed all those embedded pharmacists to find out how often they're out here in the more complicated patients. And again, we're trying to show that we're augmenting the physician so that they can have some satisfaction in their job, and by pharmacists working in that arena with direct patient care, we have satisfaction in our job. So that's kind of our goal. So this is something that came out last couple weeks ago about pharmacists providing incident to service must be an employee, leased, or contracted to a physician or Medicare Part B approved provider. I'm saying this because sometimes you're a faculty at a college, and if I were there, I'd want to see the paperwork to make sure that that there's some legal control, that the practice has legal control over that faculty person. And it's kind of like I'm a 1099 employee for IPHA, and the only way I can be a 1099 is that there's no, you guys don't have direct control over me. This is opposite. In order to bill incident 2, there has to be some legal control over it and shared control, and the expenses may include salary or non-salary support, such as exam rooms and office spaces. So these are the 3 areas you need to make sure that you have included when you approach a physician or a physician group to find a relationship. So telehealth service, real quick, had to throw this one in. We had to thank COVID for this, but it took us about 3 months because CMS forgot that DSMT and DPP were provided by accredited pharmacies in those 2 areas, and they didn't include us into that 1135 waiver, and now we are. And they also loosened up, the supervision can be provided virtually. So Jenny can be where she needed to be, and the doc that she's working with can be where they needed to be during COVID, and just so that they could talk to each other virtually, that was fine. So Jenny could still see her patients without having that process. But she's in a FQHC, but it was applied across the board for everybody. So that opened the door for us. So between our House Bill 135, our telehealth expansion, and COVID, I think it's looking good for us. So this is more about what the rules were before, and then COVID kind of blew those out of the water. And then these, I'm not going to go through these, but these are some of the other billing areas that we'll attack one at a time later on at another time. So this is IPHA's PSME 2.0. This is the version that I have dreamt about. It's a control tower where IPHA is your administrative officers, and we will work closely with all the pharmacies that want to be involved, or pharmacists, so we can have advanced clinical pharmacists that are part of a network pool, or we can have the pharmacies that are in ICPIN are part of it. We'll help with the billing and cost sharing and the logistics. And then we've joined partners with Habit New to be our virtual platform to provide the diabetes prevention program and DSME and chronic disease and the remote patient monitoring. So, and instead of each individual pharmacy having to come up with a quality assurance process all by themselves, that it'll be done through our network, and that's what the control trial will help you with. So I wanted to show you the network process that with Habit New. They built this platform that was originally just built to do diabetes prevention. And in diabetes prevention, you have 15 patients, and you follow them over a year's period of time. And when I saw their DPP program, I thought, this is going to be great for chronic disease. And they have the e-care plan, and it's all in together. And they've been partnering with us to help us create a better program. So post-assessment question 1, you know the answer to this one. It's part D as in dog. And post-assessment question number 2, it is all of the above. So I'm going to end, and then if we have stop sharing, I know there's 3 questions. Ooh. Any questions? I don't see. Salvi, did you see any?
No, I did not see any.
I think he meant understaffed with skilled medical professionals. Oh.
Yeah, no, that was.
Oh.
That was a governor.
Yeah. Snarky comment to JB.
Well, you know, I vote for pharmacy. So if you pass what, you know, we've had to work side by side of everybody, and I've been doing this for 40 years. So if you love pharmacy, then I'll vote for you. I know that was quick, and it's just the definitions. The intricacies of billing are a little more involved, so that's why we probably should take them by model type and then do little snippets of that. Or have an actual 4-day workshop. I mean, a 4-hour workshop, not a 4-day. No questions? Seriously? Sabi, do you have a question?
I do not have a question. I'm just impressed by what you did in the past 20 to 25 minutes in covering, because this is so very intricate.
It is.
We have to be very careful about, you know, how we build so that we do not get involved in Medicare fraud billing unknowingly, right? And so we have to look at all the references that we have. Also at CMS, they have resources that you can receive. That you
the
can,
Learning Network.
Yeah, and get emails from them, and you get more information about the intricacies of all the billing.
So Garth and I get about 1,000 emails a day, and my 1,000 emails is all about this. Billing and expansion, and I serve on ACCPs, ASHPs, and APHAs, business or compensation, or something to do with compensation, so that we have organized group. Even and Jenny and I and many of you are also ADCES members, and we get a lot of billing insight from the diabetes educators, maybe sometimes faster. I would say our telehealth breakthrough was because of ADCES, Ann Burns, and myself nagging the quality assurance director at CMS to go upstairs and tell Director Verma that she has all these quality assurance stats for DSMT and DPP. So they finally got tired of us. We ask the same question every Friday from April 15th. I mean, yeah, April 15th till June 15th. Tenacity.
Yeah, and I think somebody wanted to see if we could include this in the annual conference, but I guess we have to look at the schedule per Garth.
I think it's full, but we could do something special,
Right. We can do a separate workshop.
a workshop. Yeah, we've been wanting to do a workshop. I just wanted to see how much y'all were interested in it.
Well, you know what? Did you provide the link to the Understanding Healthcare Billing Basics article?
The article,
And-
I didn't because Garth was, no, I didn't.
No, it's yeah, but there is the image of the link is in the slide deck, which is shared in the chat. And
Okay.
the reason we can't share that document, it is an APHA member benefit to get it for free, and non-members do have to pay for it. So we want to respect that because it was a collaborative work of all the associations, which we're glad that Starlin's work was also recognized in that document. So I don't want to step on toes at APHA on this. So, but I am going to stop the recording here. So we'll see everyone next month, but everyone stay on here.